Now we are very happy to present to you in TCT the partnership session with AAPI, American Association of Physicians of Indian Origin. Ajay and many others also, we have cardiologists of Indian origin are having a separate association too. But my good friend, Dr. Srini Gangasani, actually we were together in a lot of things in country, and he has done some pioneering work even in these COVID times, helping our COVID patients in India. I would stress some of those aspects in his talk too. With this few words, thank you, Dr. Cindy Grines, madam, for joining and all the help from your society too. And Venkatram sir is always quite close and well-wisher. He is there for any of our meetings and always happy. Thank you, sir, for joining. With this, I request Dr. Srini to moderate the session and conduct the proceedings.
Thank you, Srinivas.
Other panelists, 1 minute. Other panelists, Dr. Arun, Dr. Kalyan, Dr. Ravi Bhattina, Dr. Khanna, Dr. Banerjee, if you are there, you please join the panel. Over to you, Srini.
Thank you, Dr. Srinivas. Really a privilege to be part of this TCT. You guys have done a wonderful job. As you're looking through the whole program, you're doing an amazing job with the whole program. Welcome to all the panelists with this AAPI session with Dr. Grines, Dr. Choksi, Dr. Mulamudi, and with the panelist, Dr. Ram, who was a past president of AAPI. I know I haven't seen Dr. Ram for a while. Welcome, Dr. Ram, and Dr. Ravi Bhattina. We've also been very active in India as well as here in Atlanta. Now we're fortunate to have Dr. Ravi Bhattina here, who is part of our eGlobal workshops when we did it. Thank you everyone for participating in this session. Without further ado, I would like to introduce my mentor from my cardiology fellowship and a pioneer in the cardiology and especially percutaneous interventions in acute myocardial infarction, Dr. Cindy Grines, who was my attending when I was a fellow at William Beaumont Hospital. Now she is a Chief Scientific Officer at Northside Hospital Cardiovascular Institute. She's also immediate past president for Society for Cardiovascular Angiography and Intervention, SCI. And she has done amazing work in percutaneous intervention world. And she has so many honors and awards. And it takes a whole 20 minutes for me to describe all of them. And she has over 600 publications for her credit. So she did her medicine at Ohio State University, did her residency at Ohio, and then did her fellowship at Michigan. And she held so many positions. I think if you put Cindy Grines' name in Google, I think it's going to take for 10 pages to go through all Dr. Grines' accomplishments over the years. Without further ado, I would like to introduce Dr. Cindy Grines, who has been my mentor and one of the greatest interventionalists I've known in the United States. Thank you, Cindy.
Srini, well, before Madam starts, when we were students, if a female cardiologist, somebody, sorry to say this, but it was only Cindy Grines at that time. Now a lot of others have also joined in the interventional arm. And yesterday, Greg Stone was also taking PAMI studies. It was the one how they conducted it when there were not proper finances and resources. But that was the studies which gave maximum benefit to the patients. And thank you, madam. We are very indeed honored to have you. Over to you for your lecture.
Well, thank you, Dr. Srinivas and Gangasani. I'm so thrilled to be here. Yeah, we go way back, don't we, Srini? So without further ado, I think we'll get started on my slides. Okay, so you can see these, right?
Yes.
Okay,
make it full screen, madam.
It's supposed to be full screen. Let me see. Let me end the slideshow. Okay, is it full screen now?
The AV team, can you help, madam?
It
is in the presentation mode, it looks, madam. That's why we are seeing the two slides, how you see on the laptop. If you...
Yeah. Sorry. We tested this beforehand and it seemed to be okay.
Arshita? Otherwise, we can see, madam. We can just continue.
And since U.S. Actually led India in terms of the presentation of the initial COVID pandemic, we have a lot of data over the course of the past year. We do know that patients with cardiovascular disease, including something as simple as hypertension, have an increased risk of mortality with COVID-19. Interestingly enough, up to 30% of patients admitted to the hospital who are COVID positive have elevated troponins. And you might be called frequently about this elevated troponin and how to manage those patients. At the same time, due to this fear of contracting COVID among the physicians and staff, and actually patients not wanting to come to the hospital, there was approximately a 40% reduction in STEMI activations to the cardiac catheterization laboratory during the first 8 months of the pandemic. And we do know that COVID positive patients with ST segment elevation present a particularly unique and challenging population. Now, part of that's because you don't really know what's going on with the patient. And as you can see from these EKGs and communication through Twitter primarily, that there are a lot of patients who had ST segment elevation. And when they went to the catheterization laboratory, they really did not have obstructive coronary disease. And so what do you do about those patients? Now, this might be due to a number of different reasons. For example, there could be some hypotension causing demand ischemia, increased metabolic demands. The hypoxia can contribute to myocardial necrosis. There could be direct viral myocarditis. There could be thromboemboli that are causing this, stress cardiomyopathy, and the hyperinflammatory state. But with all these, we obviously don't want to perform PCI. And so I'm going to try to focus here on this epicardial plaque rupture, the type 1 MIs, and what to do with them. Now, initially during the pandemic, there were several papers that came out with recommendations to consider giving thrombolytic therapy, but that's really stepping back several decades in terms of what we know about the management of acute MI. It's been proven conclusively in multiple studies that primary angioplasty is vastly superior to thrombolytic therapy. And if you think about the fact that many of these patients might not have a culprit that needs reperfusion therapy, then you're exposing that patient to the risk of thrombolytic therapy and the subsequent intracranial bleeding without any particular benefit whatsoever. So we got together, Sky initiated this consensus statement with the ACC and the American College of Emergency Physicians to talk about what we do with ST segment elevation on the EKG. If the patients are COVID positive and the symptoms and the EKG are consistent with MI, then you really just go straight to primary angioplasty. On the other hand, if there are equivocal symptoms or an atypical ECG, meaning ST elevation, not in a vascular distribution of a coronary artery, then it's recommended that you get an echocardiogram to detect wall motion abnormalities. If it appears to be a regional wall motion abnormality, again, proceed to primary PCI. If there's no regional wall motion abnormality, then you can try to manage those patients conservatively throughout their hospital course. Now, this is just a case of one of the early presentations I got this from Benita Shah, my friend from NYU. It's a COVID positive patient who had anterior STEMI. They administered bivalirudin and ticagrelor prior to getting to the catheterization laboratory. The LAD was totally occluded proximally, so they used a 2 millimeter balloon to establish flow. And what you see is an extensive thrombus throughout the entire length of the LAD, starting in the near ostial segment, going all the way down to the apex and involving a very large diagonal branch. Now, Benita went ahead and did thrombectomy of this lesion, got some moderate amount of thrombus present, but it was not resolved. So they spent lots of time in the cath lab trying to work on this. And ultimately, they gave intracoronary TPA, did not work. They had to place a catheter distally. They gave more intracoronary TPA, eptifibatide, which is a 2B3A antiplatelet, nitroprusside, epinephrine to try to reestablish flow. There's still continued no reflow in this vessel. You can see now this area has been stented, but no reflow, lack of myocardial blush, very low cardiac index, cardiogenic shock. Echo showed an EF of 20%. This balloon pump that's in was upgraded to Impella for subsequent support, but unfortunately the patient passed away. So this is a very, very challenging situation. And there are a lot of postulated mechanisms of coagulopathy. You know, there's a lot of risk factors because the patients are acutely ill and bedridden. There's a lot of inflammatory response. There's hemostatic abnormalities that can contribute to this, elevated D-dimer, fibrin degradation products, PTs, platelets may or may not be elevated. And this hypercoagulability can result in venous thromboembolism. And many of these patients die of pulmonary emboli, as well as myocardial infarction, even in the situation of no epicardial coronary artery disease. So very, very challenging. If one looks at the initial STEMI series in COVID-19, very small series from different countries. The bottom line is the hospital mortality was quite high in New York, 72% mortality. Other areas did not have quite as high of mortality in the STEMI population. So because of all this uncertainty about how to manage these patients and very little data on, who are these patients, how are they being treated, what are their outcomes, we decided to create this North American COVID-19 ST segment elevation MI, otherwise called NACME registry. And this was a joint venture between SCI, the Society for Cardiovascular Angiography and Interventions, along with the ACC. And we presented the data just recently at the SCI meetings a few months ago. And basically the inclusion criteria were any patients who were COVID-19 positive or who were patients under investigation for COVID. They had to have STEMI or a new left bundle. They had to have a clinical correlate of ischemia, for example, some sort of dyspnea, chest discomfort, cardiogenic shock, etc. And so at the time that we presented this, we had about 331 COVID positive patients enrolled, double the number of patients under investigation. An interesting thing to point out with the COVID positive STEMI population presented, 50% of them had dyspnea and only 50% had chest pain. So this is very different than the average STEMI patient who rolls in the door who does not have COVID. Out-of-hospital cardiac arrest occurred a little more frequently. In-hospital presentation of STEMI occurred in 7% of these patients. And chest x-ray findings showed about 50% of these patients had abnormalities on their chest x-ray. Another thing that's quite interesting, and perhaps we can talk about what's happening in India, but about 55% of these patients were non-Caucasian and a large prevalence of diabetes. So the Black and Hispanic population was actually much more vulnerable to have a COVID positive STEMI. With regard to the outcomes, we actually compared them to the patient under investigation shown in yellow, and we had these age and sex match controls from the previous year where patients did not have COVID. And what you see if with regard to the reinfarction rates, it's really not that much different. Stroke was significantly higher in these COVID positive patients compared to the earlier outcomes with sex and age match controls. And about the mortality rate was 33% in these COVID positive patients compared to 4% mortality in the sex and age match controls from the year before. So obviously there's a huge increase in mortality. As you might expect, the ICU stay and the total length of stay were much higher in patients who had COVID-19 positivity. Now, how are these patients managed? Remember, I mentioned that there was a lot of talk that we should be given thrombolytic therapy to these patients, but we did this study after we set out with our guidelines from SCI, and we're happy to say that thrombolytic therapy, shown here in blue, was used very infrequently. With regard to the COVID positive patients, 70% of them underwent primary angioplasty, and 23% of them were managed medically. On the other hand, those patients under investigation, 80% of them received primary angioplasty, and fewer, only 13%, were managed medically. Now, as you might remember, if you have an average patient, the non-COVID patient coming into the hospital, about 90% of the time we end up giving him primary angioplasty. So this 70% is a little bit low. And why might that be? Interestingly, about 20% of COVID positive patients had no culprit vessel identified on angiography. So this is the myocarditis or maybe the microthromboemboli causing their MI. And this was different, of course, from those patients under investigation and different from patients, the sex and age match controls. If one looks at multivariate predictors of death in the COVID positive patients, as you might suspect, the sicker patients did worse. So if you were intubated, you were independently more likely to die. If you had cardiogenic shock, If you presented in hospital with your STEMI, more likely to die. History of stroke trended to show higher mortality, patients with diabetes, and of course, advanced age. If you decided to perform angioplasty, those patients did a lot better. But I assume, we know angioplasty is beneficial, but some of that might be selection bias to treat this less sick patient. So in conclusion, I think we have a lot of information now about STEMI in the COVID-19 era. We know that there's more frequent in-hospital presentations compared to traditionally out-of-hospital development of STEMI. There's more thrombotic lesions and pathologic reports of microthrombi, more frequent no culprit being able to identify on angiographies, leading us to believe it's microemboli or focal myocarditis. Higher mortality in these patients. There initially was considerable controversy regarding appropriate management, but I think we all agree that taking the patient cath lab, figuring out what's going on is key. And then, of course, we're making that recommendation based on our guidelines. So we do believe that primary angioplasty remains the reperfusion strategy of choice, although we have many more patients with no culprit who ultimately will manage them medically. In our hospital, we recommend a rapid COVID test in all STEMI patients. In fact, all patients who are leaving the emergency room need to get this. But remember, it's false negative in 30% of all cases. And so as a clinician, we have to protect ourselves. Wear the N95s, try to be very cautious about being exposed to these patients. We recommend stronger chewed antiplatelet agents. So chewed because it increases the rapidity of antiplatelet effect. The more strong antiplatelet agents would be ticagrelor or prasugrel. And you might want to consider giving intravenous agent for an additional boost. We recommend heparin anticoagulation. The reason being bivalirudin in the past has been associated with stent thrombosis. And to try to keep the ACT on the high side of normal, particularly if a thrombus is present or the patient has an elevated D-dimer. The management of these large thrombuses, such as I showed you in the angiogram, is uncertain. But when you're in there, I think that many of us probably would do what Dr. Benita Shah did, try to do some thrombectomy, try to give intracoronary thrombolytic therapy. You might need to give higher doses, at least 20 milligrams of TPA over several minutes. And then finally, these patients have associated LV dysfunction and very high mortality. So as a clinician, I think we should really try to quickly implement things that can help with LV dysfunction, such as ACE inhibitors, carvedilol, spironolactone, and consider mechanical circulatory support earlier rather than later, particularly in those patients who are unstable. Thank you very much for your attention.
Thank you, Dr. Grines, for that wonderful presentation. I think we came a long way, even from March of last year to this, I think 14, 15 months when we started versus initially we were thinking about giving thrombolytics, and then we were really scared to take patients to the cath lab. Now we have come a long way and we are almost back to normal, of course, with a caution. Thank you for that wonderful presentation. Any comments from the panelists?
Srini, can I make one comment? This is Venkatram.
Go ahead.
You actually hit the nail on the head by saying that how fast, how quickly we have realized the spectrum of COVID in the last year, 16 months. Initially dubbed as a thing that viral pneumonia is the main reason. Now viral pneumonia is just a part of the spectrum of COVID. And this is one of the things I think historically we have learned a great deal during our lifetime. I just went to make one point. Last April, a friend of mine in Italy, Dr. Giuseppe Mancia, who is very, very well known, he called me saying, Venkata, I think all my patients are at home. I can't get hold of them. Some of them might be dying of acute MI at home, not going to the hospital. This is last April. And now we are here. So how clear the cardiovascular manifestations have been identified is really remarkable. I know that we have still ways to go to protect the patients, but the progress we have made, not only on vaccination, but cardiovascular identification and protection is one of the important lessons in our medical profession. Very, very important. Thank you for allowing me to make this comment.
Thank you. Any other comments? Dr. Arun, Dr. Choksi, Dr. Mahesh? Thank you, Dr. Grines, for that wonderful presentation. Looks like you made it so clear. Nobody has any comments and questions. Thank you. I think I remember seeing you first time doing the intervention in 1997 as a fellow, and you're the cath lab director. I think we came a long way. I'm so glad you're at Northside Hospital and working alongside of you. It's been a great honor. Thank you. Thank you very much for that wonderful presentation.
Guys, if it's okay, I have just one quick question.
Yeah, go ahead,
Thank you again. That was a fantastic talk, and I mean, kudos for having put together this endeavor and also kind of abstracting the data and presenting it now. So that's fantastic. Thank you for sharing this, Dr. Grines. So the thing that I did want to know was, I mean, you did talk about using more, aggressive anti-platelet agents. Do we have any data? Has anyone ever kind of looked and seen if, let's say, something like a rivaroxaban or something in conjunction with this long-term, like, I mean, we do it anecdotally here, 45 days for those patients with D-dimer, whether they have STMI or not, if they have a higher thrombotic risk. So let us say inside the cath lab, you've seen a lot of clot, this, that. Are you just sending them on DAPT when you discharge them? Or are you adding, like a low-dose rivaroxaban or something on top of that, especially if they are low bleeding risk?
Yeah, that actually makes a lot of sense. I don't think we have any evidence to do that, but certainly there's, if you look at the AFib population, there's a lot of safety and efficacy data if you drop the aspirin and then you just give them a P2Y12 inhibitor along with anticoagulant. I personally think the rivaroxaban would be the one I would choose because there's so much data in the coronary world, right? I mean, if you look at Eliquis and those other agents, they've not really done any studies in the coronary population. There is some concern that if you give Eliquis without an antiplatelet in a coronary patient, there might be actually an increased risk of thrombosis. So you bring up a very good point. I know that positive D-dimers or elevated D-dimers, it's a non-specific entity, but it's a higher risk population. And so I think that's extremely reasonable to give the 2.5 BID in addition to, Prasugrel or Ticagrelor.
All right, thank you.